So intensive aphasia therapy has been around for a really long time. It actually started between 1940 and 1945 with all the soldiers returning from World War II who had brain injuries and aphasia. So during that time, there was kind of a beginning of intensive aphasia therapy. Then in the 70s, there was kind of a resurgence of that where people started looking into intensive aphasia therapy, doing research. And then ever since then, there's been like 25 years of research looking at intensive aphasia therapy and its benefits versus a typical outpatient schedule of 2 to 3 hours a week. I think maybe because there are so few places that do it, people don't get exposed to it a lot, but it's definitely not something that's brand new and experimental. There's definitely a lot of research behind this. So when you're working with somebody with aphasia, you may want to know who's an appropriate person to refer to an intensive aphasia program. And there's really not kind of like a hard and fast criteria where this person's good and this person isn't. Typically, the big thing is somebody who's medically stable. We don't necessarily want to work yet with somebody who's having uncontrolled seizures or cancer treatments, something like that, who's been put on pain medication that's really affecting their thinking or how they're moving about throughout the day. Again, also people who, maybe can't stay awake, who are on peg tubes or have really severe medical issues. Those aren't people necessarily that you would want to refer. However, in general, there's no age restrictions. Anybody from 16 to 99 years old. There's no severity restrictions. So it doesn't matter if somebody's a global aphasic or has a mild anomic aphasia. We can do pretty much anything. So we've started with people who have a very severe apraxia where they can only do 1 or 2 sounds, all the way up to a mild anomic aphasia where somebody's preparing to go back to work. So there's actually a wide range of people. It can be somebody who just had a stroke a week ago. It can be somebody that had their stroke or brain injury 20 years ago. So referring is just the first step to seeing if this person's going to be a good candidate for our program. So what happens after you refer somebody is typically we talk to either the speech therapist or typically it's usually some family member who calls us or emails us. Brian, who's the coordinator, talks to them, gets some information from them, and then typically what will happen is somebody will fill out an application. So I review the application, make a recommendation for treatment, maybe if I have some questions about something the caregiver has put down. And then we kind of work with the family to see what their expectations are and what we think would be a best course of treatment for this person. So every once in a while, we'll have people that want to know, do we treat apraxia or dysarthria or primary progressive aphasia? And the answer is yes. I don't think you've ever seen somebody who has apraxia who doesn't also have an aphasia, so they're not really separable, and you can't really treat apraxia and aphasia separately. Also, dysarthria is treated. We do have people who don't necessarily have aphasia but do have the dysarthria, so that's on a case-by-case basis. And primary progressive aphasia, we've had a couple of different clients, and that is all very specific program that's made for those people. So we have to have a consultation and I have to determine what I think is going to be the best course of treatment for what that person wants to accomplish. But there is research showing that it is worthwhile to treat people who have primary progressive aphasia and not necessarily just give them an AAC device before it's time. People will say, oh, well, can anybody make progress? I thought there was this 6-month window. And that's not even necessarily true. If you look at research shows that brain scans have shown changes even up to 2 years after somebody has had a stroke. So it's not that there's this magical 6-month to 1-year window. Now, within that 6 months, there's a lot of brain reorganization and healing and clearing out the debris. So that is necessarily the best time to make rapid changes. But just like you can learn anything throughout your life, people that have had a stroke and aphasia can continue to get better and better. There's not there's no such thing as this plateau that we say somebody has reached, because all you need to do is change your approach and that person's making progress again. Common question. People are a lot of times kind of nervous about coming here if they're traveling a distance. They don't know what to expect. It's a huge time commitment. It's a huge financial commitment, but it is a commitment in their recovery and their progress. So it's never happened that somebody's come and they've not liked it. Usually after the first day or so, once people are comfortable and they kind of have an idea of how it works and what the routine is, people will actually add on weeks. They're very excited to be here and they're very excited to see how things are done here. In the event that somebody came and they didn't like it, nobody ever pays for treatment that they don't get. So in the event that somebody wanted to leave, they would have their money, they'd only pay for what treatment they got. Additionally, if there's holidays or things like that, then we make up the hours or they just don't pay for that particular day. So within about 15 minutes of the facility and the housing, there's 3 major hospitals. There's also a ton of outpatient clinics, and then every apartment has a folder in it. So when people arrive, they know where the Coumadin clinics are, they know where the labs are, all of that relevant medical information. In general, just let people know when they're being discharged that there is such a thing as intensive aphasia therapy. I wouldn't worry so much about whether you think they can afford it or not, unless obviously they're on Medicaid. But there are a lot of people who have had fundraisers, they've had GoFundMes, there are some people who've gotten partial scholarships. There are people who will find ways to get the money if they want to do it. So I would say all you need to really do is let people know that it is an option, and then they can find out whether they can afford it or not. Additionally, something that's really important that the outpatient or the last therapist can do is, if you recommend or the doctor recommends intensive aphasia therapy, sometimes they can get a pre-authorization from their insurance, and then we can help them get some money back from their insurance. So there's different ways to kind of work this, but we don't know how we can help somebody or kind of what's possible given a budget if we don't ever get to talk to them. You can also look and see if there are any student programs. There are a couple of intensive student aphasia programs that you can look into too, for people that have Medicaid or people that you feel wouldn't be able to travel. Treatment really varies. Everybody's doing 5 hours a day, and then they have the OT twice a week. So at a minimum, you're doing 25 hours a week plus the 2 hours of OT. Now, the session lengths are anywhere from 4 weeks to 8 weeks. So if they haven't been to an intensive aphasia program before, typically the standard recommendation is going to be 6 weeks, and here's why. There's a kind of a typical cumulative progression that you see in people. So 4 weeks is when most people with a more severe aphasia or even a moderate aphasia are just getting to where they can carry over a lot of these strategies, or they're just kind of getting to the next level in their language or their reading or their writing or even their compensatory strategies. There's an awareness that comes around, or a comprehension shift that comes around the 4th week, that if somebody leaves right after that, there's so much more that we could have carried over within that 2 weeks, so they're at a better place when they leave to be able to keep working towards the next level. The 4 week is for people who have a really mild aphasia or who only want to work on maybe one thing. 8 weeks, we would say, is kind of for people that are more severe. However, there's a lot of people who may be very nervous, and so they'll schedule a 4 week and then end up extending to a 6 or an 8 week. Also people who would schedule a 6 and then extend to an 8 because they're doing so well. So our goal is not to take your outpatients or your inpatients or to steal anybody from anywhere. Our goal is just for you as the last therapist. A lot of people come here and the families, they say, oh, we were just discharged suddenly, and we were given no resources. We had no idea what to do. We had to do all this research ourselves. So they don't really know a whole lot about what their options are. you as the final therapist who is going to be seeing them or discharging them can at least say, here are these options, here are these resources, you may want to check them out and see if it's something that's going to be right for you. Everything here is individualized, which means that it's specifically for that person. It's not for everybody with Broca's. It's not for everybody with this type of aphasia, because that's really not a thing. You don't treat people according to their diagnosis. You treat them according to what is specifically an issue with them, and then you do modified evidence-based treatments that are going to actually help that person generalize, because everything we do is going to generalize to real life. So it's very functional types of things that you don't really get a chance to make a dent in when you have somebody for 2 hours a week. And even once people leave, we don't just say, okay, see you later. We have online therapy that we can follow up in. We will train anybody that's going to work with them that's a non-therapist. And then those people are always part of our family. So anytime there's an issue or anything that they need, they can call us up or email, and that's no charge or anything like that. Is that we actually have it so that the caregiver doesn't really have to worry about too much. Now, our housing that we have here, this is not an inpatient program. Our housing is about 7 minutes away in a little place called Gulfport. But all of our condos are fully furnished. They're 1 or 2 bedrooms. They have a kitchen. They have washers and dryers. They are literally on the water, and they're absolutely gorgeous. And so many people have said that it was so nice to be able to kind of have that scenery or that peaceful backdrop while they were sitting here doing their therapy. We also include the client lunches every day, so they don't have to worry about any of that. Now, lunch here, we all eat lunch together, so that's actually a therapeutic activity that we're doing. So we have lunch together, everybody as a group, and then we'll have a short group afterwards. That also includes any kind of community outings that we would do, going to restaurants or ordering from Starbucks, anything that we're practicing that then we would go do in the community. It includes the Aphasia Action Plan. So when people leave here, they have not just a report of, okay, this is what you did and this is how you did, but this is your customized program of what we did here and what we want you to continue to do when you go home, so that you can give this to anybody that you're going to work with, or if the family is going to do it, then the family knows exactly what they're doing. We give you all the materials and the step-by-step breakdown of, okay, this is how you do it. This is how you make it easier if there's problems. This is how you make it harder if there's problems. But it's not just this generic, like, oh, you might want to do this or you might want to do that. It's incredibly specific, and it's detailed into specifically what they're doing and why they're doing it. Occupational therapy is something that is included at 2 hours a week. Sometimes people add extra if they want to, because once they meet Carolyn, they are thrilled with her approach, because it's not the same thing that they're doing in the hospital either. It's more challenging, and she can do not just the upper extremities, but kind of look at the whole body holistically. So she also supplements what we're doing in aphasia therapy when she's doing her OT. So what we do for testing here is typically the first day, day and a half, everybody's doing a standardized test. Now, we do have some tests that we've made because standardized testing doesn't fit. It's not really helpful for people who have a higher level aphasia or people who have more of a global aphasia. It's kind of better for those in-between people just to get an idea. So we do some pre-testing. At the end, we do post-testing. We don't put a lot of emphasis on test results because, as you know, standardized testing is not made to be able to show changes between pre and post, and also because there's a lot of aphasias or a lot of progress that can be made that can't be tracked by a standardized test that only accepts verbal responses or only accepts repetition of the directions one time, where we can't paraphrase or do something like that. Post-testing, but the more important thing is we reassess informally everyone every single day, every hour, to see, okay, if we use this approach, is this a promising approach? Typically, you're going to know within a couple of hours. If not, we can stop that immediately and move to something else, because we've seen so many people with so many different types and severities of aphasia that we have a really good understanding and a really good idea of what this person is doing, and okay, if we can't go about it this way, can we look at it, can we come from a different angle and still get where we're trying to go with this. We also do use technology, if appropriate, in our sessions, and that's not teaching somebody how to use apps or something like that. It's more, we can work on texting, we can work on email reading and writing, and this is for anybody, not just necessarily people with mild aphasia. So we have different types of hierarchies set up and how we deal with each type of thing.